Hello, everyone. My name is Christine Cooper, and I'm a public health advisor at the CDC Foundation. I'm an field employee at the CDC on the maternal mortality prevention team on the Division of Reproductive Health at the CDC. And thank you for this opportunity to present a mixed methods analysis of pregnancy-associated overdose deaths review 2018 through 2020 in Massachusetts, North Carolina, Ohio, Tennessee, Utah, and Wisconsin. I'd like to start by sharing some of the background for this analysis, why we are looking at pregnancy-associated overdose deaths, and provide some context for maternal mortality review committees and the data they can provide for preventing pregnancy-associated overdose deaths. Studies from 2018 through 2020 have found some concerning trends in opioid use during pregnancy and specifically opioid use among pregnant persons. The prevalence of opioid use disorder, or OUD, among pregnant persons increased by 333% between 1999 and 2014. The proportion of pregnant persons with OUD admitted to treatment for substance use disorder increased from 17% to 42% between 1996 and 2014. And more recently, data analyzed from 34 jurisdictions in 2019 found that 6.6% of respondents reported prescription opioid use during pregnancy. Among these individuals, 21.2% indicated misuse and 27.1% reported wanting or needing to reduce or stop using opioids during pregnancy. We also know from several studies that opioid use during pregnancy has been associated with negative infant and maternal outcomes, including preterm labor, neonatal abstinence syndrome, intrauterine growth restriction, and stillbirth among infants, and depression, anxiety, and chronic medical conditions among birthing persons. But before I go on, I want to give you some context for maternal mortality review committees. Maternal mortality review committees, or MMRCs, seek to provide a deeper understanding of maternal mortality through understanding both the medical and non-medical contributors to death and developing and prioritizing recommendations that may reduce future deaths. They do this by reviewing death certificates and any linked birth or fetal death certificates, medical records, social service records, mental health records, autopsy, and in some cases, informant interviews. Note that MMRCs include representatives from public health, obstetrics and gynecology, maternal fetal medicine, nursing, midwifery, forensic pathology, social work, mental health and behavioral health, and members of the community. It is also important to start with some definitions that are critical to the discussion on maternal mortality in the US. The term pregnancy-associated death is an overreaching term that describes the death of a woman while pregnant or within 1 year of the end of a pregnancy from any cause. The whole tree here represents pregnancy-associated deaths. Pregnancy-related deaths are the subset of pregnancy-associated deaths that are causally related to pregnancy, shown here in pink. These deaths are a result of pregnancy complications, a chain of events initiated by the pregnancy, or the aggregation of unrelated conditions by the psychological effects of pregnancy. A clear-cut example of a pregnancy-related death is an amniotic fluid embolism. And then pregnancy-associated but not related deaths are those shown in turquoise that result from a cause not related to pregnancy. A clear-cut example of a pregnancy-associated but not related death is a death caused by a natural disaster such as a hurricane that just happens to occur during pregnancy or the year postpartum. This map shows almost every state has an MMRC or is planning one, while 3 states in Puerto Rico are planning that review process. I wanted to share this map to show how many MMRCs are currently meeting and reviewing deaths in the United States and even at the local level. CDC supports 50 state and local MMRCs in this work by making the Maternal Mortality Review Information Application available. MMRIA, or MARIA, is a CDC data system that provides a common data language for MMRCs, facilitating their function and promoting a national approach. Of 50 existing MMRCs, 48 currently use MARIA. MARIA facilitates documentation of a wide range of data on the life and death of a woman to ensure a review committee can develop strong prevention recommendations. Over time, we've added components to Maria based on feedback from users that facilitated enhanced data collection on things like substance use, discrimination, and racism. As more states collect comparable review data with a truly multidisciplinary membership that is reflective of the communities most impacted, the data will improve and point the way to eliminate preventable pregnancy-related mortality in the US. Now to focus on the Rapid Maternal Overdose Review, or ARMOR. This initiative supported 6 states in comprehensively reviewing all pregnancy-associated overdose deaths, having the right people on the committee to review an overdose death, such as a mental health or addiction specialist, and then the timely analysis and dissemination of findings and recommendations. The states that participated in ARMOR can be seen here on the map. We have Massachusetts, North Carolina, Ohio, Tennessee, Utah, and Wisconsin. Focusing on the data in this analysis, we're looking at pregnancy-associated overdose deaths from the ARMOR states that occurred in 2015 through 2019 and were reviewed 2018 through 2020. There were 104 overdose deaths included in this analysis, and these were deaths where the committee indicated the means of fatal injury was poisoning or overdose, and an additional 9 deaths were identified by manual review by epidemiologists on a maternal mortality prevention team. So all of our quantitative numbers come from these specific inclusion and exclusion criteria. And then looking specifically at the qualitative data sources, we reviewed case narratives, contributing factors, and committee recommendations to prevent future deaths for these identified 104 overdose deaths. Now we can get to the results. These reviews were for deaths that occurred from 2015 through 2019. The individual characteristics are similar to overdose deaths occurring more in non-Hispanic white individuals. We also see that the majority of deaths occurred for individuals who were 25 to 34. And of interest was the high number of individuals that had Medicaid during pregnancy or at delivery. Focusing in on timing, you can see that most pregnancy-associated overdose deaths occurred in the late postpartum period. In fact, 73% of them did. Among pregnancy-associated overdose deaths, where autopsy records were documented, the most common observed substance was opioids, with 85% of the deaths indicating the presence of an opioid. Within those deaths, where an opioid was present, fentanyl was found in the toxicology results of 58, or more than half of the overdose deaths. "89% of women and other pregnant and postpartum people had a history of substance use in their records. Among those 93 individuals, 44 have a history of substance use treatment. Focusing on the timing of treatment, we see that most of the 44 individuals received treatment before the sentinel pregnancy, and treatment decreased the most after pregnancy. These groupings are not exclusive, and one person may have received treatment prior to pregnancy, during pregnancy, and after the pregnancy. But importantly, we see that after pregnancy, the fewest individuals received treatment. Looking at substance use screenings, only 50% of pregnancy-associated drug overdose deaths had substance use documented in the prenatal records. There were several factors captured in the qualitative analysis that could contribute to the missed opportunities for screening and getting individuals into treatment for substance use disorder. Factors captured that could contribute to these missed opportunities included some individuals in the analysis had missed an incomplete prenatal care, narrowing the window for screening. It was also more common to see substance use screenings in emergency department records in the ARMOR data, which are often not shared with primary, prenatal, labor and delivery, or postpartum care providers. 72% of women and other pregnant and postpartum people had evidence of mental health conditions in their records. Among these 75 people, 59 had a history of mental health treatment. While a large portion of these individuals, 93%, received treatment prior to pregnancy, it's important to note this could have been any time before the sentinel pregnancy, and a larger portion of time is covered in this chunk. We also found in the data What we found in the data is that 75 individuals had evidence of mental health conditions, but only 33 individuals received treatment during pregnancy and 35 individuals received treatment after pregnancy. There was some crossover between these groupings. Again, they're not exclusive. And so I want to highlight that note at the bottom, that these groupings that one person may have received treatment prior to pregnancy, during pregnancy, and during the postpartum period. An important part of understanding what was captured in the ARMOR data came from the qualitative analysis of the case narratives in the committee decision forms. This process allowed us to provide more context for the quantitative data captured in Maria, specifically the stressors that individuals experience. And multiple stressors were found around housing instability, including homelessness, violence, sometimes across their lifespan. This included intimate partner violence, childhood trauma, personal and familial physical, sexual abuse, and rape. Individuals also experienced incarceration prior to, during, and after the sentinel pregnancy, sometimes disrupting appropriate substance use and prenatal care. We also saw financial instability and unemployment, and a theme of loss of child. This theme included the death or loss of a child or children to stillbirth, induced or spontaneous loss of pregnancy, and the removal of children by Child Protective Services or loss of a child to custody issues. There are some specific areas on the committee decision form we'll be sharing from the 104 deaths received as a part of the ARMOR analysis. Of these deaths reviewed, specifically looking at the pregnancy relatedness as defined earlier, and the committee determinations on circumstances surrounding the death. The committee determines if obesity, discrimination, mental health conditions other than substance use disorder, and a substance use disorder contributed to the death. The committee checks a box for yes, probably, no, or unknown when there is not enough information. Focusing on page 2 of the committee decision form, committees determine preventability with a yes or no, as was this death preventable. And then if they answer yes, the death was preventable, they have to determine if there was a good chance, some chance, no chance, or unable to determine the chance to alter the outcome. The committee also determined contributing factors and recommendations to prevent future deaths. This information captures the committee's review of the death and what can be done for preventable deaths to prevent these deaths in the future. 17% or 18 deaths were determined to be pregnancy related. 77% were determined to be pregnancy associated but not related. And an additional 6 deaths, the committee was unable to determine the pregnancy relatedness. So the majority of pregnancy associated overdose deaths were pregnancy associated but not related. Looking at preventability, 89% of the deaths were determined to be preventable by the review committee. Among the preventable deaths, there was some chance to alter the outcome for 69% of individuals and a good chance for 29%. As I shared earlier, committees make a determination of circumstances surrounding the death and whether some conditions contributed to the death, specifically looking at contribution and not just presence. Committees found mental health conditions other than substance use disorder contributed to nearly 3/4 or 72% of pregnancy-associated overdose deaths. And committees determined that substance use disorder contributed to death in 94% of the cases. Interesting context for these numbers, there was documented missed opportunities for mental health screenings, especially beyond postpartum depression, yet mental health issues were a leading contributing factor to pregnancy-associated overdose deaths. We see here that nearly 3/4 committees determined they contributed. And abstractors also documented barriers to substance use treatment, including unstable living situations and financial barriers. There's also documented difficulty in finding substance use providers and facilities that accept Medicaid or treat pregnant individuals. There were 523 contributing factors by MMRCs for the 97 of 104 persons identified in this analysis. Contributing factors are organized by class and level with a free text description. So for example, at the class was referral, At the provider level, and the description of the issue would be lack of referral for treatment or substance use disorder. MMRC cases reviewed from 2018 to 2020 found 207 contributing factors assigned at the patient family level, 112 contributing factors assigned at the provider level, 46 contributing factors assigned at the facility level, 97 contributing factors assigned at the system level, 61 contributing factors assigned at the community level. Let's look at each of these levels more closely, along with the recommendations to address contributors at these levels. I'm not going to go through all these classes for the sake of time, but we see that substance use disorder and mental health conditions were the top classes assigned by the committee at the patient and family level, accounting for almost 40% of the contributing factors. Looking at some of the qualitative examples, you will notice in the review that these examples that contributing factors determined by the committee at one level may need input from another level in the recommendations. For example, while all of these contributing factors are assigned to the patient and family level, so the patient did not continue with methadone treatment, the input may be from the system or the provider level. So the example here was the system should improve reputation and services provided by the area hospitals and how they treat individuals with substance use disorder, so patients are more likely to seek care there instead of fragment their care. At the provider level, we see that continuity of care and care coordination and clinical skill quality of care were the top classes assigned by the committees, accounting for 48% of the contributing factors. Again, looking at some of the qualitative examples, we see early discharge with no follow-up in patient with no prenatal care and positive cord screen, and that providers should arrange for postpartum follow-up and referrals for patients with substance use disorder and or mental health conditions. At the facility level, we see that continuity of care, care coordination was the top class assigned by the committees, accounting for 43% of the contributing factors. And again, looking at some of the qualitative examples, at the top, we see that needed seamless transition from one care site to another with accountability for outcome was the contributing factor, and the recommendation made by the committee was to improve handoff communication between inpatient and outpatient facilities, improve inpatient and outpatient care referrals, and secure handoffs and accountability for results. At the system level, we see that continuity of care, care coordination, access/financial, and policy/procedures were the top classes assigned by the committees, accounting for 53% of the contributing factors. Again, focusing in on some examples, we see in the middle here that loss of custody of child as a trigger for relapse was identified as a contributing factor, and that Child Protective Services should appoint a navigator and counselor for parents who are working through the process to regain custody to support and enhance process for family reunification was the recommendation from the committee. And finally, looking at the contributing factor classes at the community level, we see that access/financial and knowledge were the two major classes identified, accounting for 48%. And looking again at some of the examples, we see in the center here, lack of childcare and transportation for childcare was identified as a contributing factor, and that transportation and daycare should be provided when there are mandated community service or work requirements by whatever organization is requiring the service or work in advance of the requirement going into effect as the recommendation that came from the committee. In conclusion, from all of this, we see that the major contributors of mental health and substance use need to be addressed. In addition, there is need to remove barriers to treatment for individuals who are pregnant and beyond the first 42 days of the postpartum period. As highlighted in the Maria data qualitative analysis of case narratives and the committee decision form, there are missed opportunities for screening, referral, and treatment. In addition to access to appropriate substance use and mental health care and treatment, there is need for continuity of care to be addressed and to prevent, if we're going to prevent future pregnancy-associated overdose deaths. I hope this presentation and analysis shows that MMRC recommendations provide opportunities for data to action at the local and state level and highlight the quality of data MMRCs can produce to prevent pregnancy-associated overdose deaths in the future. Thank you for this opportunity to share the ARMOR analysis. It's been wonderful to share these findings with you, and I hope you all have a great day.